Chronic obstructive pulmonary disease, COPD. Omar Al-Amoudi, MD, FRCP, FCCP, FACP. Professor, Consultant Pulmonologist. Drimaudi@yahoo.com. Definition of COPD. COPD is a chronic obstructive pulmonary disease that is characterized by airflow limitation that is not fully reversible. The airflow limitation is usually both progressive and associated with an abnormal inflammatory response. COPD is a preventable and treatable disease. Chronic obstructive pulmonary disease, COPD. Chronic bronchitis. Emphysema. COPD. Definitions. Chronic bronchitis, cough and sputum production for at least 3 months in each of 2 consecutive years in absence of other endobronchial disease such as bronchiectasis. Emphysema, overinflation of the distal air spaces with destruction of alveolar septa. Prevalence of COPD worldwide and in KSA. Prevalence/risk factors. Cigarette smoking. Cigarette smoking is the primary cause of COPD. Approximately 90% of COPD patients have a smoking history. The WHO estimates 1.1 billion smokers worldwide, increasing to 1.6 billion by 2025. In low and middle-income countries, rates are increasing at an alarming rate. Smoking prevalence among doctors. Country male %, female %. UK 85. USA 97. Germany 96. Korea 46-28. China 42-35. Arabia 38-15. Global burden of disease, 1990 to 2020. Lower respiratory tract infections. 1. Diarrheal diseases. 2. Conditions during perinatal period. 3. Unipolar major depression. 4. Ischemic heart disease. 5. Cerebrovascular disease. 6. Tuberculosis. 7. Measles. 8. Road traffic accidents. 9. Congenital anomalies. 10. Malaria. 11. COPD. 12. 1. Ischemic heart disease. 2. Unipolar major depression. 3. Road traffic accidents. 4. Cerebrovascular disease. 5. COPD. 6. Lower respiratory tract infections. 7. Tuberculosis. 8. War. 9. Diarrheal diseases. 10. HIV. 11. Conditions during perinatal period. 12. Violence. The global burden of COPD will increase enormously over the foreseeable future as the toll from tobacco use in developing countries becomes apparent. COPD is expected to rise from 12th to 5th as a cause of lost disability-adjusted life years, DALYs, within the next 20 years, Murray and Lopez 1999. DALYs are a composite measure of the burden of a health problem and are a sum of the lost years due to premature mortality and years of life with disability, adjusted for the severity of the disability. Lopez ad. Murray CJL. The Global Burden of Disease, 1990 to 2020. Nature Med 1998, 4, 1241 to 1243. COPD prevalence in KSA. COPD prevalence in KSA, KND. According to one report released by the Executive Office of the GCC Health Ministers Council, Saudi Arabia is the world's 4th largest importer of cigarettes. During the year of 2004, the kingdom imported 41,000 tons of tobacco at a value of near 1.45 billion. Table 3. Ranking of the 10 most frequent diagnoses among hospitalized patients at COW. Diagnosis: no %. Diabetes mellitus 570 10.5. Ischemic heart diseases 493 8.6. Bronchial asthma 311 5.8. Chronic liver disease 293 5.4. Congestive heart failure 203 3.8. Hypertension 153 2.8. Sickle cell anemia 141 2.6. COPD 132 2.4. Chronic renal failure 116 2.1. Cerebrovascular accident 108 2.0. 11. 12. Risk factors. Risk factors for COPD. Host factors. Genes, for example alpha-1 antitrypsin deficiency. Hyperresponsiveness. Exposure. Tobacco smoke. Occupational dusts and chemicals. Infections. Socioeconomic status. Aging populations are risk factors for COPD. Nutrition. Infections. Socioeconomic status. Aging populations. Pathogenesis of COPD. Noxious agent, tobacco smoke, pollutants, occupational agent. Pathogenesis of COPD. Noxious agent, tobacco smoke, pollutants, occupational agent. COPD. Genetic factors. Respiratory infection. Other amplifying mechanisms. Source: Peter J. Barnes, MD. Pathogenesis of COPD. Cigarette smoke. Biomass particles. Particulates. Host factors. Amplifying mechanisms. Lung inflammation. Antioxidants. Antiproteinases. Oxidative. Stress. Proteinases. Repair. Mechanisms. COPD pathology. Causes of airflow limitation. Irreversible. Fibrosis and narrowing of the airways. Loss of elastic recoil due to alveolar destruction. Destruction of alveolar support that maintains patency of small airways. Airway pathology in COPD. Airway pathology in COPD. Airway pathology in COPD. Diagnosis of COPD. Diagnosis of COPD. A clinical diagnosis of COPD should be considered in any patient who has dyspnea, chronic cough or sputum production, and/or a history of exposure to risk factors for the disease. The diagnosis should be confirmed by spirometry. A post-bronchodilator FEV1/FVC less than 0.70 confirms the presence of airflow limitation that is not fully reversible. Comorbidities are common in COPD and should be actively identified. Indoor/outdoor pollution. Diagnosis of COPD. Exposure to risk factors. Symptoms: cough, tobacco, sputum. Occupation: shortness of breath. Indoor/outdoor pollution. A diagnosis of COPD should be considered in any patient who has cough, sputum production, or dyspnea and/or a history of exposure to risk factors. The diagnosis is confirmed by spirometry. To help identify individuals earlier in the course of disease, spirometry should be performed for patients who have chronic cough and sputum production even if they do not have dyspnea. Spirometry is the best way to diagnose COPD and to monitor its progression, and healthcare workers to care for COPD patients should have access to spirometry. Spirometry. Diagnosis of COPD signs: hands, flapping tremor, dilated veins, collapsing pulse, warm hands, CO2 retention. Cyanosis, clubbing of the finger, CA lung, Chest, signs of hyperinflation. Barrel chest, use of accessory MS, decreased expansion, absence cardiac dullness, tracheal tug. Hyperresonant on percussion, diagnosis of COPD, sign of pulmonary HTN. Increased JVP, left parasternal heave, loud P2, hepatomegaly, ascites, lower limb edema. Fundus examination. Papilledema. Extrapulmonary manifestation. EMS wasting. Signs of COPD. Diagnosis of COPD, spirometry. Spirometry should be performed after the administration of an adequate dose of a short-acting inhaled bronchodilator to minimize variability. A post-bronchodilator FEV1/FVC less than 0.70 confirms the presence of F-flow limitation that is not fully reversible. Diagnosis of COPD, spirometry. Spirometry, normal and patients with COPD. Classification of COPD severity. By spirometry. Stage I, mild FEV1/FVC less than 0.70. FEV1 greater than 80% predicted. Stage II, moderate FEV1/FVC less than 0.70. 50% less than FEV1 less than 80% predicted. Stage III, severe FEV1/FVC less than 0.70. 30% less than FEV1 less than 50% predicted. Stage IV, very severe FEV1/FVC less than 0.70. FEV1 less than 30% predicted or FEV1 less than 50% predicted plus chronic respiratory failure. The effect of smoking on lung function. FEV1% of value at age 25 years. 100. Never smoked or not susceptible to smoking. 75. Smoked regularly and susceptible to its effects. 50. Stopped at 45. Disability. The course of COPD varies greatly from person to person. This chart depicts the decline in lung function with age and the possible contribution of smoking to the progression of COPD. Smoking is considered the most important risk factor for the progression of COPD. Additional risk factors include genetic contributions, such as N-1 antitrypsin deficiency, airways hyperresponsiveness, occupational dust/chemicals, pollution, infections and poor socioeconomic status. The exact mechanism of poor socioeconomic status as a risk factor is unknown, although it could be due to a combination of other risk factors such as exposure to pollutants, infections and poor nutrition. Fletcher, Peter RBMJ 1977, 1, 1645–1648. 25. Stopped at 65. Death. 25. 50. 75. Age, Y. Adapted from Fletcher and Peter 1977. Diagnosis of COPD, chest X-ray. Diagnosis of COPD, HRCT scan. Diagnosis of COPD/A.B.G. Measurement of ABG type 2 respiratory failure. PCO2. PO2. Alpha antitrypsin deficiency screening. COPD at young age group. Plus WE family history. Diagnosis of COPD CBC/WBC, increased with infection. HP, secondary polycythemia. ESR increased with infection malignancy. Diagnosis of ECOPD. Diagnosis of ECOPD. Diagnosis of ECOPD was based on ATS criteria. Major. Increased dyspnea. Increased sputum production. Purulent sputum. Minor. Cough, wheeze, sore throat, and cold and nasal discharge. Diagnosis of COPD/sputum culture. Pathogens isolated during exacerbation. Bacterial. Moraxilla cottalis. Pseudomonas. Haemophilus influenza. Viral. Influenza. Atypical bacteria. Mycoplasma. Chlamydia. 44. Differential diagnosis COPD versus asthma. Differential diagnosis, COPD and asthma. Onset in midlife. Symptoms slowly progressive. Long smoking history. Dyspnea during exercise. Largely irreversible airflow. Limitation. Onset early in life, often childhood. Symptoms vary from day to day. Symptoms at night/early morning. Allergy, rhinitis, and/or eczema also present. Family history of asthma. Largely reversible airflow limitation. COPD and comorbidities. COPD patients are at increased risk for myocardial infarction, angina, osteoporosis, respiratory infection, depression, diabetes, lung cancer, pulmonary hypertension in COPD, chronic hypoxia, pulmonary vasoconstriction, muscularization, intimal, hyperplasia, fibrosis, obliteration, pulmonary hypertension, new, copulmonal, edema, death. Source: Peter J. Barnes, MD. Management of COPD and exacerbation. Management of COPD prevention. Smoking cessation is the single most effective and cost-effective intervention in most people to reduce the risk of developing COPD and stop its progression. Controlling pollution, reduction of total personal exposure to tobacco smoke, occupational dusts and chemicals, and indoor and outdoor air pollutants are important goals to prevent the onset and progression of COPD. Management of COPD smoking cessation. Counseling delivered by physicians. Numerous effective pharmacotherapies for smoking cessation are available. Nicotine chewing gum, transcutaneous patches, nicotine inhalers or nasal spray. Bupropion, aminooctone, reduce nicotine withdrawal symptoms. Epilepsy, tremor, insomnia, tachycardia. Nortriptyline, management of COPD bronchodilators and anticholinergics. Ipratropium bromide, short-acting. Improve nocturnal O2 saturation. Improve quality of sleep. Doses, 40 micrograms 1-2 puffs Q6H. Mainly used during exacerbation and symptomatic patients. Management of COPD bronchodilators. Tiotropium bromide, long-acting anticholinergic. Once daily. No systemic cholinergic effect. M3 receptors antagonist. Dose, 18 micrograms/day. Used in combination with LAB ±ICS or alone in stable COPD. Decrease symptoms, improve exercise tolerance. Decrease exacerbation. Management of COPD bronchodilators. Sharp S2 agonists, salbutamol, terbutaline. Rapid relief of symptoms. Dose, 120 micrograms, 2 puffs Q4, 6 hours. Tachycardia, tremors. Methylxanthines, theophylline. Weak bronchodilator effect. Monitor serum level, 55-110 micromoles/L. Hepatic disease, heart failure, drugs, erythromycin, ciprofloxacin increase serum level. Management of COPD long-acting bronchodilators, LAB. LAB is more effective and convenient than treatment with short-acting bronchodilators. Samitrol, 50 micrograms. Formoterol, 9 micrograms. Doses, Q12H. It should be added with ibuprofen or tiotropium if further improvement in symptoms is required. Glucocorticosteroids. Management of COPD. Glucocorticosteroids. Long-term use of ICS treatment is appropriate for symptomatic COPD patients with NFEV1 less than 50% predicted, stage 111, 1 volt. Repeated exacerbations. Allergy. Budesonide 800 usig BD. Fluticasone 500 usig BD. Chronic treatment with oral corticosteroids should be avoided because of an unfavorable benefit-to-risk ratio. Other pharmacologic treatments. Management of COPD. Other pharmacologic treatments. Antibiotics, only used to treat infectious exacerbations of COPD. Respiratory stimulants, improve ABG. Doxapram. Olmitrine. Mucolytic agents, antitussives, not recommended in stable COPD. Pharmacotherapy, vaccines. Management of COPD. Pharmacotherapy, vaccines. Influenza vaccines can reduce serious illness and should be given yearly. Pneumococcal polysaccharide vaccine may be given although there is no conclusive evidence to support its use in COPD. Non-pharmacologic treatments. Management of COPD. Non-pharmacologic treatments. Rehabilitation. All COPD patients benefit from exercise training programs, improving with respect to both exercise tolerance and symptoms of dyspnea and fatigue. Oxygen therapy, LTOT, greater than 15 hours per day, to patients with chronic respiratory failure has been shown to increase survival. PO2, 55 mm of mercury or less. PO2, 59 mm of mercury plus polycythemia, copulmonal. Management of COPD. Surgical management. Bulectomy. Resection bulla allow expansion of the surrounding lung tissue. Lung volume reduction surgery. FEV1 less than 35%. Lung transplant. Age less than 65. FEV less than 35%. PaO2 less than 55 mm of mercury. PaCO2 greater than 55 mm of mercury. Secondary pulmonary HTN, absence of IHD. Management COPD exacerbations. Antibiotics. Second-generation cephalosporin. Amoxicillin, clavulanate. Quinolones. Inhaled bronchodilators, combination of ibuprofen. B2 agonist. Management COPD exacerbations. Corticosteroid. 4-methylprednisone. Oral prednisone. Should be used in moderate to severe COPD. Hydration. Chest physiotherapy.